Good morning, everyone. This is Leslie again. I would like to introduce Sarah Aker, the Deputy Division Director for Medical Services, that is going to be giving a Medicaid overview to everybody today on the webinar. Welcome, Sarah.
Thanks, Leslie. Again, my name is Sarah Aker. I'm the Deputy Director in the Division of Medical Services. I have been giving this presentation, I feel like, to new staff over the last year, but if you have any questions during the presentation or something specific you want to know about Medicaid, feel free to stop me and ask a question. So at its core, Medicaid, like you're probably aware, is really a health insurance program. That's what we do and what Medicaid is funded for. Medicaid was started in 1965 under the Social Security Act, and later CHIP was added in 1997 as another amendment to the Social Security Act. Medicaid is what's called an entitlement program, so that means that anyone who's eligible for Medicaid has to receive services, so it doesn't matter if there's 10 people eligible or 100,000, we're required to provide services to anyone who meets our eligibility criteria. Our population is really geared towards economic eligibility conditions, so we're really serving low-income children and families who don't have access to private health insurance usually, as well as people with chronic illnesses or disabilities. The other important thing to note about Medicaid is that it's a federal-state partnership, so that means the federal government funds part of the Medicaid program and the state funds part of the Medicaid program as well. However, each state administers their own Medicaid program. There's something that we like to say that if you've seen one Medicaid program, you've seen one Medicaid program. They vary drastically between state to state. There are certain federal minimums that every state has to meet or cover, but beyond that, states really have the ability to design a program that really reflects their state's needs and really meets kind of the program designations that that state is elected to cover. The final thing that we always like to point out is that Medicaid is not Medicare. Medicare is a federally funded program. It's entirely federally funded. It's entirely federally administered, and it's specific to people who are over age 65 or disabled. Medicaid, however, is really, or I guess what I'd like to say is that it's possible to be eligible for both Medicare and Medicaid. A lot of individuals that are served by our HCBS waivers are eligible for both programs, and sometimes I think they have trouble understanding the differences between Medicare and Medicaid, but they are two separate programs. The next piece I want to talk about is how Medicaid is financed. So I talked about how Medicaid is both a state and federal partnership. And really where that partnership is most evident is in the FMAP, or the Federal Medical Assistance Percentage. That's the percentage of dollars that are paid for by both the state and the federal government. So for every dollar we spend in Medicaid, about 54 cents of that dollar is paid for by the federal government, and about 46% is then paid with state dollars. The FMAP for federal fiscal year 17 is about 54% federal and 46% state. It varies from year to year, and it varies based on the federal fiscal year. So that means the FMAP changes on October 1st of every year. The FMAP never goes below 50%, so the federal government's always going to contribute at least 50% of the cost towards Medicaid, and it never goes above, I want to say, 80%, so states always have to contribute at least 20%. It ranges, though, depending on how well a state's doing economically. So states that are doing better economically compared to the rest of the country have a lower FMAP. They move closer towards that 50%. States that are doing less well comparatively have a higher percentage of dollars that are funded by the federal government. The federal or the FMAP formula is based on a state's median income. So as the median income changes in a state, it then reflects a change in the state's FMAP. So we're pretty close to 50, which means that's good news for South Dakota. That means we're doing pretty well economically. However, that does mean the state's contributing a greater share of federal dollars. Every 1% change in the FMAP is equivalent to about $7 million in state general funds. So when that fluctuates either up or down, that really can drive the state's budget and kind of what expenditures need to be allocated to Medicaid. There are kind of some different FMAPs for either different programs or different populations. One example is CHIP, the Children's Health Insurance Program. has a different FMAP than the regular Medicaid FMAP. And it's currently inflated right now from the ACA, so the CHIP FMAP for this year is actually at 91% federal funds and 9% state funds. There's also certain services that are eligible for different FMAPs. So for example, services that are received through IHS are eligible for 100% federal funding, or services that are referred through IHS with a care coordination agreement are also eligible for 100% federal funding. There's populations that are eligible for an enhanced FMAP as well. So under the Affordable Care Act, the Medicaid expansion population would have been eligible for a 90% federal match with a 10% state match. The other piece of that is there's certain services that are eligible for enhanced funding as well. So for example, family planning services are always eligible for a 90% federal match and a 10% state match. Are there any questions about the FMAP? All right. I'd like to talk a little bit about who we serve in general in Medicaid. For the most part, our program is really geared towards children in South Dakota. We serve about 68%, children, and about the other 32% are adults. Our adults fall into a couple of big categories. The first is pregnant women. We also serve low-income parents, so parents who have a child at home under age 18 that qualifies for Medicaid. And then we also have our elderly and disabled population. I want to note that our adult coverage is pretty limited. You really have to have one of those qualifying disabilities or be a very low-income parent, about 52% of the federal poverty level. Economic assistance performs all of the eligibility determinations, and they work with other agencies when there's a need for kind of an assessment of a disability or a level of care in concert with that eligibility. So I like to kind of take our group of individuals and put it kind of roughly where our expenditures are in comparison. So like you see, children account for 68% of our population, but they only account for 35% of our expenditures. Our biggest expenditure category is really our age, blind, and disabled adults. They account for quite a large section of our expenditures overall, mostly because they have higher health needs or more complicated conditions that require a greater kind of percentage or a greater amount of care than what we typically see with our kids. Our kids are usually pretty healthy, and so they usually have pretty low expenditures. Just to give you an idea about where kind of someone's income falls, we've included this slide. This is actually the 2016 calendar year guidelines. I haven't updated them for 2017 yet in this PowerPoint. But if you're thinking about, for example, our parent or caretaker relatives, they fall at about 52% of the federal poverty level. So if you looked at a family of four, 100% is $24,000 per year about. So in order for a parent to qualify, they have to be making about $12,000 a year to qualify for Medicaid. Our kids, however, we have kind of a much more generous coverage limit for them. So under CHIP, we cover kids up to 209% of the federal poverty level. So a child could be in a family of four making up to about $51,000 per year and still be eligible. Our age, blind, and disabled adults, there's kind of estimates associated with that. Those are really more tied towards what the Social Security income levels are set at, but they equivalent to about 74% of the federal poverty level for an individual that's living by themselves, and in a couple, about 83% of the federal poverty level. So in state fiscal year 16, we covered about 147,000 people in South Dakota on Medicaid. That's an unduplicated number. On average, we cover about 118,000 in any given month. It really fluctuates depending on someone's income situation. They can go on and off Medicaid depending on what changes they have in their income through the year. That equivalates to, though, about 1 in every 7 South Dakotans in any given month have health coverage through either Medicaid or CHIP. 1 of 3 children under the age of 19 will have coverage through Medicaid or CHIP, and about 50% or half the children born in South Dakota will be on Medicaid or CHIP during their first year of life. We also like to point out that about 35.5% of our population is American Indian. and they comprise a large section of our Medicaid eligible population. I always like to include these statistics because I think it's important to note that it's likely, even though we don't think about maybe that we know someone on Medicaid, we probably do, because it's such a large section of our population that's covered either through Medicaid or CHIP. So in terms of regulations, Medicaid is subject to a lot of them. We have both federal regulations and state regulations. We also have what's called the Medicaid State Plan, which is a contract between the state and the federal government, which really describes how South Dakota administers the Medicaid program. So it designates DSS as the single state agency for overall administration of Medicaid, and really puts DSS as kind of the oversight for any programs that are administered using Medicaid funding. So now that LTSS is part of the division or the Department of Human Services, DSS maintains a role providing oversight of the waiver. The state plan, anytime we want to change it, we have to do what's called a state plan amendment. Those can be for things like changes to service limits, or they can be tied to when the legislature appropriates inflation. We have to make a state plan amendment that designates that appropriation for providers. There's a formal process for making changes to the state plan. An amendment has to go through a public notice process and tribal consultation. Then we submit it to our regional office in Denver for approval, and they work with central office in Baltimore to give us full approval of a state plan amendment. That process is pretty prescribed. It lasts about 90 days start to finish once we've sent it to CMS. However, they have the option to request additional information from us, which can extend that process. Most of our state plan amendments, though, are approved within that 90-day time frame. It's similar to the process that a waiver has to go through for an amendment or for a renewal. However, contrary to waivers, the state plan is, once it's approved until we, the state, choose to amend it again. We do not have to go every 5 years and kind of reauthorize our state plan. It's in effect until we choose to change it. The state plan is on our website if you ever need some reading material that will probably put you to sleep. It's about 700 or maybe closer to 800 pages, I think, if you want to read it. If you don't want to read it and just want to know something about it, feel free to email either me or Matthew Ballard is our state plan amendment specialist who really coordinates that process for us. In terms of other regulations, federal rules really are in either the Social Security Act or in the Code of Federal Regulations, or CFR. CFR defines kind of the mandatory things that we have to do, things that we have to cover, and populations that we have to cover in order to receive federal funding. And then it also provides for additional things or benefits and populations that we can choose to cover if a state elects to do that. CFR is changed periodically. Maybe so, for example, Congress may amend the Social Security Act, which will then prompt changes to CFR, which then may require us to amend our Medicaid state plan or change some of our administrative rules or other policies and procedures. In terms of state rules, we have our administrative rules of South Dakota. This is where we implement a lot of federal and state legislative mandates or changes. Our state rules are really more specific than what our state plan says. So, for example, the Code of Federal Regulations says that we can cover vision benefits. Our state plan says that we cover it. And our administrative rules get more down into the details. So it says that we cover new glasses for someone every 18 months if a vision change is medically necessary. So our administrative rules really speak to even more specificity than in either CFR or in our state plan. We also have our Medicaid provider manuals, which contains even more kind of detailed guidance around billing for providers. So this slide talks about some examples of things that states are required to cover. It's things that you'd expect: inpatient, outpatient services, physician services, nursing facility is another Medicaid mandatory service. And then on the other side, or that other section of it, are things that the state has the option to cover. Some things that I like to point out as an optional service is prescription drugs. Every state has elected to cover prescription drugs, but it's technically an optional service under CFR. Some things that we cover that other states don't necessarily cover Our dental, especially dental services for adults, a lot of states have very limited dental for adults, and while we do have some limits on dental services, we do have that benefit available to our entire population. So our budget in Medicaid is vastly approaching $1 billion. We're at $892.3 million in the last state fiscal year. And it's a large part of the state spending. It crosses into a bunch of different state agencies. Most of it is centered in the Department of Social Services as the designated state Medicaid agency. But all of our waiver expenditures are located in the Department of Human Services now. We also have some programs and services that are offered through the Department of Health. Medicaid funds, health insurance for individuals who are or juveniles that are in the custody of the Department of Corrections. Medicaid funds or pays for beds in the state nursing or state veterans home in Hot Springs, the Department of Military and Veterans Affairs. And then we also pay for services in school districts, so some services that are on IEPs, as well as some services that are offered through Birth to 3. So when you look at where our expenditures kind of fall, the majority of our expenditures are really associated with kind of institutional type of care or its equivalent. So a lot of our top spending category is hospital services. It accounts for about 25% of our overall expenditures. The next group is really kind of an interesting combination, but it includes our nursing home care, our assisted living care, and then our hospice. And then our community support providers, which are individuals who serve people on the Choices waiver. Then as we go down the list, you'll see physicians make up quite a bit of spending, as does Indian Health Service. Pharmacies are a large part of our spending as well. And then our 2 state-based facilities, the Developmental Center and Human Services Center, are listed. We have our substance abuse and mental health providers. And it kind of goes down the list until we get to like our dentists and in-home service providers, and then some emergency transportation or ambulance services. So in terms of some other Medicaid operations, we're a division of about 52 people. We're mostly located in Pierre, but we have a couple nurses that are located in Rapid City and Sioux Falls. We have a lot of different kind of units within our division. So, for example, we have our provider enrollment staff who are tasked with ensuring that providers meet all the federal and state standards to become a Medicaid provider, and that they continue to meet those standards and remain an eligible provider. So that means they're checking to make sure that provider has never kind of gotten into trouble with either Medicaid or Medicare in another state or within our state. They're making sure that that individual has an active license if that's needed to verify that they're doing a background check. There's quite a few different things they have to check off a list in order to meet all the federal requirements for enrollment. We have currently about 15,000 enrolled providers. This last year we were required to do what was called revalidation. It's a component of the Affordable Care Act, which basically means we required all of our providers to go through and look at their enrollment information, update it, and fill out some additional paperwork that was required as part of the Affordable Care Act. We're still completing that process. It's been pretty intensive to re-enroll 15,000 people at the same time. We also have a large number of our staff that work in claims processing. So we have a telephone service unit that can answer questions for providers about claims that they've submitted or other questions. They also directly process those claims. We're one of the only states that still does that. A lot of states have third-party administrators that process their claims, but we still process all of our claims in-house. In state fiscal year 16, we processed about 5.3 million claims and answered about 90,000 calls from providers. We also have quite a few program integrity functions within kind of internally, and we also have external audits that we're also subject to. The CSRS unit, though, is located in our division. They perform review of processes kind of post-payment. So after a claim's been paid, they're looking at statistics to see if a provider has suddenly started billing a lot more than they did last year, or if they're doing something that appears on the surface to not be proper. And so what they do is then investigate those. They sometimes request medical records or request other information from a provider. A lot of times those can be solved with education or, working out with a provider to let them know that they were billing improperly and changing that billing practice and returning any funds that were paid improperly. In cases where fraud is suspected or credible cases of fraud, we refer those to the Medicaid Fraud Control Unit, which is located in the Attorney General's office. And that's where that provider would potentially be subject to criminal proceedings. There's also South Dakota Foundation for Medical Care, reviews a lot of our inpatient hospital claims to ensure that there's a quality component that's occurring, and to make sure that the hospital has correctly coded those claims to us, so that they're telling us the things that they actually did and not telling us that they added some extra stuff just so they can get paid more, but making sure that they're really coding in accordance with what's documented in their medical records. ORFE is located in finance, and they conduct investigations of recipient fraud and recoveries, and payments from third-party liability sources. So Carmen asked how to make referrals to the SERS unit when we suspect payment fraud by providers. So you can call our phone number, our 605-773-3495, to make those referrals. Right now, you could also email those referrals to Lori Lawson, or you can email Misty, and she can definitely pass those on as well. It's always best, if you suspect that there's fraud, to go through our SERS unit first, to make sure that we have the ability to do a preliminary investigation. So if any of those ways is a way that you could refer those to SERS.
And this is Beth, and I'll just add to that, if you suspect that we need to send something to the SERS, we would obviously want to be notified as well of that, meaning here at state office. So just include us on the notification, or start with us, and then we can collaborate with SERS as well.
In terms of what information you need to initiate that referral, it's helpful if you have that provider's information, such as their MPI number or name, and then probably a description of why you think fraud has occurred, that you can pass on to Misty, and they can pass on to medical services. Our last kind of piece that we do in-house in terms is our drug utilization review. So we work with SDSU and a team of physicians and pharmacists across the state to review drug profiles. So we have certain kind of algorithms that we use to determine if someone's maybe receiving medicines that are contraindicative. So, if they're receiving medicines that don't necessarily work together, we inform the physicians about that. Also, if someone's receiving narcotics from multiple providers, we let those providers know to try to combat against, misuse of the prescription drug program. We also have quite a few federal audits. I haven't listed them specifically in this presentation, but one that we're going through right now is our PERM audit. It happens every 3 years, and it's a federally conducted audit looking for payment error rate measurement is what PERM stands for. But it's looking at both eligibility for Medicaid, so determining if someone's eligibility was correctly assigned, as well as ensuring that Medicaid paid that claim appropriately in accordance with our state plan and with our prescribed kind of payment methodologies. So they pull a sample of claims. Providers are then usually contacted to submit additional records about those claims, so they may be asked for medical records. A team of independent contractors that's hired by CMS reviews those claims, and then works with our office if there's any error rates or errors that would need to be corrected by the provider, and any funds that may need to be returned. Yep, waiver claims are included in the PERM cycle, so they're part of the universe that we submit to PERM. We submit all of the claims for a given, I think, for a quarter, and then they pick a random sample of those claims. So it's possible that providers could be selected within that universe. Nursing facility claims would also be part of that. Any claim that really is submitted to Medicaid for any Medicaid dollar could potentially be pulled as part of the PERM sample. So I also want to talk a little bit about our Medicaid Recipient Handbook. I usually like to hand these out and give you my 5-minute spiel about them, but it's available online and in all the local offices. I like to talk about the Medicaid Recipient Handbook because I know every Medicaid recipient is supposed to receive one. I also know that most Medicaid recipients do not necessarily read their handbook, which is, I wish more of them did, because there's a lot of really valuable information about Medicaid programs and policies and their benefits. If you're talking to a recipient, I think it's helpful if you mention the recipient handbook and kind of talk about how important it is to review that periodically so that they know more about their health insurance and how it works. I've outlined in sections that I think are most important. I'd argue that all of the recipient handbook is very important. However, I think some of the big things to note are this on page 1, for example, the Medicaid ID card. It's really important that recipients take that with them to appointments. It's how the recipient or how the provider knows that that recipient has Medicaid and how they know to bill Medicaid. So, for example, if they go to the physician's office and don't ever tell them that they have Medicaid, the physician doesn't know to bill Medicaid. Providers have 6 months to bill us from the date of service. So if that recipient never tells that provider within the first 6 months after receiving a service that they have Medicaid, then after that 6 months has passed, the provider can't bill us anymore, and it really becomes a responsibility of the patient or the recipient to pay for that service since they didn't let the provider know that they had Medicaid. We see that sometimes with, especially sometimes our pregnant women. It often happens where the pregnant woman gave their information about billing Medicaid to the provider or to the hospital, but they never followed up with the hospital and told them their child's Medicaid ID number or that their child became eligible for Medicaid. And then the hospital doesn't, of course, know that they can bill Medicaid for those services or what Medicaid ID number they need to bill with. So it's really just important whenever you're talking to a recipient to remind them to do that. We also like to point out the emergency care information that's on page 9. Recipients should always go to the emergency room when it's a real emergency. However, services that aren't a true emergency or that could be treated by a primary care physician, we'd encourage them to go to a primary care physician if possible. If a recipient goes to the emergency room and it's not a true emergency, those services do become the responsibility of the recipient at times. Also, payment of Medicaid medical bills. So Medicaid, whenever we pay for a service, when Medicaid pays for a service, that's considered final payment. The recipient isn't required to make up a difference in payment between what Medicaid paid and what the provider would charge. It's considered a final kind of payment. So if a recipient is getting a bill from a provider, it's really important that they do not ignore those bills and that they look to how they can address those. If it's a provider is trying to balance bill them or billing them for a remainder of services. The provider is not allowed to do that, so they should be contacting the provider and telling them, no, Medicaid's paid for this service, so therefore you can't bill me any remainder. Sometimes, though, if they haven't told Medicaid or told the provider again that they have Medicaid as a payment option, the recipient might think that that claim has gone to Medicaid and that they aren't responsible for the bill, but usually if they're receiving a bill, it's because the provider doesn't know that they have Medicaid potentially and hasn't been able to bill Medicaid because of that. We often don't hear from recipients until they're being sent to collections, which by that point it's really hard for us to make a payment on those bills, usually because it's past that 6-month timely filing period. So if a recipient is ever getting a bill, it's really important that they talk about follow up on that and look for ways that they can do that. The other piece I like to remind people of is the adult dental limit. Adults are subject to a $1,000 limit per state fiscal year. And so anything above and beyond that $1,000 becomes the responsibility of the recipient within that state fiscal year. Out-of-state services. So all out-of-state services that are not an emergency require a prior authorization from South Dakota Medicaid. Out-of-state means not in South Dakota or within a 50-mile border around South Dakota. So, for example, if you go to Sioux City for services, that's considered kind of on the same level as an in-state service because of its proximity to South Dakota.
Sarah, this is Beth again. One thing I would add as an exception to that rule is any out-of-state nursing facility placement. Anytime somebody goes out of state, whether it be within that 50-mile radius or not, they need to be contacting our office to get that prior authorized.
Yep. On page 23, it reviews non-emergency medical travel assistance. So anytime a recipient has to travel out of town for an appointment, so if they have to drive themselves or maybe a family member is driving them to an appointment, they're eligible to receive reimbursement for mileage and in some cases meals and an overnight hotel stay if the travel meets a certain threshold. The contact information is really valuable on page 30. I direct recipients if they have questions to contact the recipient liaison at DSS. That's Teresa Campbell, who's a really valuable source for recipients when they are encountering issues with Medicaid bills or they have a question about what's covered or not covered. And then the other important numbers is a section we've added as kind of a fillable page of their Medicaid recipient handbook for individuals to list contact information for places they receive care from, so their primary care physician or others. That's a great place for them to write down your number or their caseworker's number, so they have that when they need to when they have questions or when they need to get a hold of someone. So we had a couple questions come in through the chat. So I think the first one was from Pam. When a consumer becomes eligible for Medicaid waiver services, when should they get their card? Unfortunately, I do not know that answer. Economic assistance generates those cards and sends them. If a recipient has not received a card, though, within the first month that they've been eligible for Medicaid or determined eligible, likely that card has either gotten lost in the mail or something else has happened to it. They can request a new card from their local office, from their caseworker, or by contacting the state office in Pierre. Pam also asked if a consumer has Medicare, a supplement insurance, and Medicaid, what is the order for payment? Is Medicaid last? Yes, Medicaid is always last. We always pay after everyone else is paid or potentially paid on a claim. So if a recipient has, say a recipient has Avera insurance, they're also eligible for Medicare, and then they're eligible for Medicaid. Their Avera insurance would pay first, then Medicare would pay, and then if there's anything left over, Medicaid would pay the remainder of charges up to our allowed amount. Are there any other questions? So Karen said that she was told that EA orders the Medicaid card when they send out the approval letters. That sounds right to me. I'm not intimately familiar with that process, but again, if a recipient loses their card or they haven't received one, likely within the first month, they should always be contacting their local office or the state office to get a new card. Another program in our recipient handbook that I just want to talk about briefly, I don't have a slide here on it, but it's our Health Homes program. The Health Homes program is for individuals with 2 or more chronic conditions or 1 chronic condition or at risk for another chronic condition. It's really designed to be a program that looks at care for a whole person. So really looking at what other barriers does someone have that's keeping them from being healthy. So maybe that person needs some community resources, maybe that person doesn't have stable housing and they need assistance finding that. Maybe that person never makes it to their medical appointments because they don't have transportation and they don't have anyone that they know that can take them to the doctor. Individuals can be eligible for that program and also be eligible for a waiver. If an individual on the waiver does receive a letter of eligibility for the Health Homes program, we really encourage them to think about how that might benefit them. The waiver would also become kind of a part of their care team potentially, addressing some of their more home and community-based needs, while the Health Home really addresses more of their medical and maybe mental health needs as well. Our Health Homes can be either a community mental health center or a primary care provider clinic. As well as IHS. All of our IHS clinics and locations in South Dakota participate as health home providers. We do not have health homes providers in every area of the state, where there's some pockets where we don't have health home providers that have elected to become that. It's an optional program for both recipients and providers. We don't require them to participate. And a recipient can elect not to participate at any time. If a recipient is eligible, though, and there's a provider in their area, or their current provider is a health home provider, we really think it adds and helps that recipient address maybe some of their more complex conditions. It can really benefit them in a multitude of ways. We've seen some really positive outcomes from our Health Homes program. We started it in 2013, and we've seen both a reduction in kind of costs for that population, as well as healthier outcomes in kind of a variety of areas.
Sarah, this is Beth, and how would our staff know if somebody's eligible for health homes or participating in that program?
Sure. If you have access to the SW95, in red on the recipient screen, it'll say eligible for health homes. Sometimes it'll say opt out of health homes if they've chosen not to participate, or it'll say like enrolled in health homes, I believe is what it says on the SW95. They can also, I guess, talk to your recipient if that's something that you know that they might have 2 or more chronic conditions. It might be something that they might benefit from if they're, for example, having some issues with their physical or mental health. I can send a list, Beth, of all of the chronic conditions that someone might have to qualify them.
Great.
As well. So the last piece we wanted to talk about was Medicaid waivers and how they kind of fit in with our other state plan benefits. So a waiver is a method for a state to test a new or different way of delivering services and paying for healthcare services. There's a couple things that you can't do, however. We can't waive the basic tenets of Medicaid. We can't just have a waiver that says the state still gets the funds, but we're not going to provide the services. There's some waivers, some limitations on capping enrollment for an 1115 waiver that really deals more with kind of the provision of Medicaid state plan services. And the biggest provision that applies to all waivers are that they have to be cost or budget neutral. That means we're really tasked with making sure that they wouldn't cost more than the traditional way of providing those services. So for, are you guys calling it the HOPE waiver now? For the HOPE waiver, that would be making sure that you're not exceeding the cost of nursing home services, because that would be the traditional way of providing services to the population you serve.
Not on an individual case-by-case basis, though, but
kind of overall.
Comprehensively, correct?
Yep. Waivers can vary from federal Medicaid requirements in certain areas. That means we can have special services that are available for just certain populations. We can require or only serve people that meet a certain level of care. We can serve a different population than we normally cover. So for example, an individual who is served by the HOPE waiver wouldn't normally be eligible for Medicaid because they aren't a parent or caretaker relative and they don't meet our federal income guidelines for some of our other aid categories. But because they meet the requirements for the waiver eligibility, they're able to be eligible for Medicaid. One thing I always like to point out is that a benefit of becoming eligible for a Medicaid waiver is not only the services provided through the waiver, but that they become eligible for full Medicaid as well. So that means that they have the benefit of having Medicaid to pay for their hospital expenses, physician expenses, prescription drugs, and those types of services. There's a specific process to obtain waivers. It requires an application and public notice. There's a series of kind of negotiations between the state and the federal government about the terms and conditions of the state's proposal. 1915C waivers, like the HOPE waiver, have more of a defined process. 1115 waivers, which are more geared towards waivers of the state plan, are a little bit more, I guess they're less well defined than the process for 1915C waivers. HCBS waivers, which are 1915C waivers, allow states to provide a focused set of services to usually a targeted group. And they aim to really provide services in someone's home or community as opposed to more expensive care in an institutional setting. So we have 4 HCBS waivers. They're now all operated by the Department of Human Services. Again, I need to update this slide because you guys are now the HOPE waiver. What does HOPE stand for? Again?
Home and Community-Based Options and Person-Centered Excellence Waiver.
We also have the Choices Waiver and the Family Support 360 Waiver that are operated by the Division of Developmental Disabilities, and then the Assistive Daily Living Services Waiver. We also, our states also have the ability to request research and demonstration project waivers, and these are really ways for a state to test a new idea or evaluate kind of an experimental service or policy that differs from our existing kind of way that we typically provide services. This can be expanding eligibility to people who aren't otherwise eligible for Medicaid. It could be providing services that aren't typically covered, or using kind of a different service delivery system with the idea that it's going to improve care, increase efficiency, and reduce costs. That's really the goal of all Medicaid waivers, is to test ways to reduce costs for the Medicaid program. We have one demonstration project. It's called Money Follows the Person. Money Follows the Person is, well, I guess before Money Follows the Person, there was really two pots of money. There was your home and community-based services money that could be used for an individual in the community, and there was a pot of money for an individual who's living in an institution or receiving services at a hospital or something like that. However, there wasn't any money to get the person from the institution back to the community. And that's really where MFP is supposed to come in and help transition someone from an institution to the community. So a lot of times we've seen, for example, that maybe someone had an accident or had a major surgery, they entered a nursing facility for some rehabilitation. Following that, their family members maybe thought that they weren't ever going to leave the nursing facility, so maybe they sold their house or their furniture because, well, they don't need those when they're in the facility. That person is then improved enough that they could leave the facility, but now they don't have a place to go to, they don't have any furniture at home, or there's just some other kind of barriers. Maybe now they have a wheelchair and there's stairs to the house and they physically just can't get up the stairs, and that's the reason they can't leave. So MFP is really geared towards kind of addressing those needs for an individual. So it's helping people with who are living in an institution, which could be a nursing facility, a hospital, an ICF, or some other type of institutional type of care. It helps them transition to the community. So in order for someone to be eligible for MFP, they have to be a South Dakota resident. They have to be 18 years or older. They have to have been in that facility for at least 90 consecutive days, and they have to meet Medicaid level of care and financial eligibility criteria for at least 1 day prior to transition. So that means they have to meet criteria for the waiver at least 1 day prior to when we move them from the nursing facility to the community. They have to have at least one paid Medicaid day in that institution. So a lot of times you'll see an individual enter a nursing facility and they have resources that they can use to pay for that. However, nursing facility care is expensive. They often sometimes run out of resources and become eligible for Medicaid while in the institution. They have to reside in qualified housing upon transition. So we have to meet certain expectations for where that person is going to live after they move into the community. So they could live in their home, either their own home or a home with a relative, or they could live in an apartment and that really requires the individual to have a lease, to have lockable access with a living, sleeping, bathing, and cooking area. Some of our assisted livings are age eligible to qualify as that apartment. However, not all assisted livings necessarily meet that definition. The person has to be willing to enroll and has to be supported through one of our HCBS waivers. So they have to either join the HOPE waiver, the Choices waiver, the Family Support, or the ADLS waiver after they transition. And they also have to want to live in the community or receive services in the community setting after they transition. So the demonstration services that are offered through MFP are our transition services, non-medical transportation, assistive technology, some consumer prep, and behavior crisis intervention services. So I'll just go through these pretty quickly here. So transition services are what we find that we use the most in MFP. Those could be things like paying a deposit on someone's apartment. It could be paying for some household essentials, so maybe buying someone some needed furniture. It could also be a security deposit or a utility deposit. some rent payments. Maybe that individual, if they're eligible for Medicaid, they likely don't. They're living on a fixed income. When you live in a nursing facility, you're only allowed to keep $60 of your Social Security payment every month, and so it's really hard for someone to maybe have that first month's rent. But then after they transition to the community, they're able to usually take on those payments themselves. We can pay for some home modifications if they're needed prior to transition. We can pay for some groceries to get that person kind of started for their first month, and any startup kind of service fees that might be needed as well. We have a limit of $2,500 in this area. That's what we try to stay under for most transitions. We, similar to the waiver, have an exceptions process where we can exceed that in cases where it's necessary or needed. However, in general, we try to keep all expenses in this area to about $2,500. The next one is transportation services. MFP can help an individual with some non-emergency or non-medical transportation. So we can pay for things like bus passes, maybe a taxi or a gas card, especially within that first month of services. This service is limited to about $500 per participant. Assistive technology can be any necessary medical equipment that person needs in order to safely transition to their house. So maybe they need a shower chair or a roll-in shower. Maybe they need a lift chair or something else that really is suited to or necessary for them to live safely at home. We have about a $5,150 limit on this as a benefit. However, we again can exceed that in circumstances where it means that participant is able to safely transition home. Consumer prep, this is a service that's offered currently through the ADLS waiver, but we also offer it through MFP. It's really about, or the service is really for consumers who might need help adjusting to life at home or in the community upon leaving the institution. So maybe they had a major accident, and it's really things have really changed for that person about how they're going to live in their day-to-day life, or how they're going to communicate their personal needs to their caretakers and others. So this service can really help them prepare for living on their own and in the community. And the final service is behavior crisis intervention. This is really for individuals that, transition can be a really hard time for people. It can, there's a lot of, anxiety that can come with moving from an institutional care setting where you have kind of 24/7 access to caregivers to living in a community setting where maybe you don't or have more independence. You're, don't have as many supports to rely on a 24/7 basis. So this can help address any kind of behavioral needs that are associated with that transition. So I know someone had forwarded, I think Kelsey had forwarded some questions about MFP prior to today's call. One question was if MFP has a cap on how much funding we provide per person. We really try to stick to the maximums that are outlined in the program. It allows us to really budget for the duration of the program to make sure we're able to target all of the individuals that we'd like to through MFP. However, we can exceed those limitations or those caps when it's medically necessary for someone and will help them transition safely. She also asked if there's kind of a distinction about which program funds what items or what services. For example, does MFP purchase an item for a recipient or does LTSS? So MFP is really tasked with providing things up to the point that individual transitions to the community. So things that will help them live safely or transition safely at home. After that person is home, they should really be going through the waiver to request those services or needed items, just like any other consumer. MFP does have the option to fund services for individuals for a full 365 days after they transition. So if there is something that the waiver cannot provide, MFP can step in at that point However, we found that really our waivers are meeting the needs of our recipients. We haven't found a need for MFP to really provide additional services after someone transitions. MFP is really just doing a lot of the transition work up front. And then the last question was, how long does MFP follow along with that person? And that is, again, for that full 365 days. The transition coordinator might not be as involved in that process. Really, when someone transitions, they really hand off that care to the specialist to really take on that person's care like they would any other consumer. The MFP program, though, does have a couple quality of life reviews that are done at 11 months and then 24 months following transition. It's some federal reporting requirements that we have to do as part of the program to really talk about how that person's quality of life has changed as a result of their transition from an institution to a community setting.
Great, thank you, Sarah. Does anybody have any other questions for Sarah? We have a little bit of time left on our webinar today, so we'll give you all a few minutes to either unmute and ask your question or type it in the Q&A before we end today's call. Okay, we did get a question from Peggy. It says, is Independent Living Choices going to continue to assist LTSS with Money Follows the Person?
Yep, Independent Living Choices is one of our transition coordinator agencies. We have the same regions that you have for ADRC as MFP regions. ILC is responsible right now for 2 of those regions, and they'll continue to be a transition coordinator in those regions.
Any additional questions? Okay, well, on behalf of LTSS, I'd like to extend our thanks to you, Sarah, for your time today. Oh, of course, one last question here. For the 90 consecutive days, if the consumer would be hospitalized during that time, would the 90 days start over?
So a hospital is an institution, so that could be part of the 90 days. In fact, we've seen that sometimes where the 90 days is part of a hospitalization and partly in a nursing facility. If you do have any individuals that you know of that you think would be a good candidate for MFP, please feel free to forward their information to Sarah Spisick. She's our Money Follows the Person program coordinator, and she's based out of Sioux Falls. She's really tasked with determining some of the initial eligibility requirements for an individual, and then if they meet those initial kind of eligibility requirements, passes them along to our transition coordinators to really start the transition process. Yeah, if you have questions about Medicaid moving forward, you can feel free to outreach me. You might get a better response, though, if you outreach Leslie or Misty. I am rarely in my office or looking at my emails, so they can sometimes track me down a little bit better, or can track down somebody else in our office that might know the answer.
All right, thanks again, Sarah, and I hope the rest of you have a great day. Thanks, everybody.